Hi, this is Kathy Cannon from the Pamrevlumab Muscular Dystrophy. I would like to thank everyone for joining us today. We have an exciting discussion from FibroGen, who will discuss some changes in their anti-fibrotic program, and we're excited to hear what those changes are. Just a little bit of housekeeping before we get started. You'll notice that you're all on mute. If you have questions that you need to ask, please type those in the chat box, and we'll try to organize those so that we answer them at the end of the webinar. At this time, I'd like to introduce Eva Carrier. Eva is the Executive Director of Clinical Development for FibroGen, and she's going to lead us through this webinar. Eva?
Thank you, Kathy, for this kind introduction. Thank you, all attendees, for joining us this morning and this afternoon. Today, I will give update on the FG-3019-079 trials, which is a trial of Pamrevlumab. That's the new name for FG-3019, a human monoclonal antibody that we want to use in children, non-ambulatory subjects with Duchenne muscular dystrophy. Before I proceed and discuss the clinical trial, I would like to provide some background information, a mechanism of action, and basically our hypothesis on why we believe this new compound in this indication may actually work. So again, the previous name, FG-3019, was changed last year to Pamrevlumab. We call it PAM to make it easier. And this was a novel investigational agent for treating fibrotic and fibro-related disease, fibroproliferative diseases. In FibroGen, we have, with this agent, 11 phase 1 and phase 2 clinical trials, which are completed or ongoing. And these are not related to DMD. The only one trial related to DMD at this point is 079. Up to date, approximately 556 patients have been enrolled in Pamrevlumab clinical studies sponsored by FibroGen. About 451 patients have received Pamrevlumab, and about half of this patient number, have received treatment for more than 6 months. We've observed very carefully the safety profile of this compound and have not seen so far safety signals that might prevent further development of the drug. Again, about 451 patients already received Pamrevlumab. It was well tolerated, and there were no dose-limiting toxicities. Any adverse events were mild or moderate. And also, of course, we have been looking if there is proof of concept in patients, and we have detected this in pulmonary fibrosis, idiopathic pulmonary fibrosis called IPF, as well as pancreatic cancer. I would like to give you just a very short update on the IPF trial. So we have completed a 1-year open-label phase 2 trial in 89 patients and showed that in about 30% of these patients there was reversal of lung fibrosis and also improved lung function. And this data was recently published in European Respiratory Journal, number 47, and we can provide the copy of the manuscript if requested. At this point, regarding the IPF, we are conducting a randomized placebo-controlled phase 2b trial with 160 patients and eagerly expecting the results. In terms of pancreatic cancer, we have completed phase 1-2 trial in 75 patients, and this data showed dose-related improvement in survival of these patients. And this data was recently published in Journal of Cancer Clinical Trials. It's number 2, and again, if anybody would like to look at this paper, we'll be happy to provide. At this point, we have ongoing phase 1-2 trial in 42 patients with locally advanced disease in pancreatic cancer, and we'll be analyzing these results probably within a year or two. Now, very briefly, I will provide the rationale for treatment of DMD with Pamrevlumab. So, bottom line is that DMD is a fibrotic disease. At the top, we have a muscle, and this can be damaged and is damaged through repeated cycles of muscle degeneration and regeneration in DMD. Through this damage, there is a large amount of cells, inflammatory cells, that are driven to this environment and growth factors. The satellite cells are activated, the myoblasts are produced, and there is a transformation of the myoblast to fibrous tissue. They produce fibrous tissue. As you can see here, there is accumulation of fibrous tissue. This is why I said in the beginning that this is a fibrotic disease. So basically, the lack of dystrophin leads to muscle damage. This activates cells and releases cytokines, inflammatory cytokines, and produces fibrous tissue. This accumulation of fibrotic tissue in the muscle will then prevent normal muscle function because the Pamrevlumab is anti-fibrotic agent. We hypothesize that with this agent there will be slowing or reversal of fibrosis and therefore enhanced regeneration or possibly enhanced function of the muscle. Again, this is our working hypothesis. In contrast to this, you can see a normal regeneration of the muscle and which creates normal muscle function and also morphology. However, in DMD, this is not the case. And so again, fibrosis arises from a buildup of CTGF, which is connective tissue growth factor, and this leads to abnormal cells and collagen accumulation. So here you have a human muscle tissue, which is normal here on the left. However, on the right, this is a DMD patient tissue that shows accumulation of collagen. These are these red circles that you can see around muscle fibers. Also, here you can see this is a quantitation of collagen and CTGF and TGF and fibronectin in patients and normal tissues. So the empty bars are controls and the black bars are patients, and you can see that there is increase of collagen as well as CTGF in DMD as compared to normal tissues. So our hypothesis is that blockage of connective tissue growth factor with Pamrevlumab may impact fibrosis. So on the left, you can see normal wound healing. So there's injury, platelet activation, cytokine activation, and increased vasculature, wound contraction, and wound healing. So there's restoration on the normal tissue. However, in DMD, there's a chronic injury, chronic inflammation, necrosis. There is persistent myofibroblast activation, and as an endpoint, which I have shown before in previous slide, there is this fibrotic tissue formation, a fibrosis. And therefore, Pamrevlumab, which neutralizes excess of CTGF, may prevent or decrease or stabilize this fibrotic tissue formation and enhance muscle function. So this diagram shows very well the MOA and also the hypothesis that we are working with. So to summarize, here on the left, there is a scarring in DMD in the muscle, which is the fibrous tissue. And accumulation of this fibrous tissue leads to decreased vascularity, increased fibrosis, and also decreased regeneration. So this situation on the left represents situation in DMD. However, on the right, if Pamrevlumab treatment would decrease fibrous tissue formation, we could increase vascularity, blood flow, decrease fibrosis, and also increase muscle regeneration. And that may lead to increased muscle function and improvement of quality of life of these patients. So again, the rationale, just to summarize what I have shown, for Pamrevlumab as a treatment for DMD is for CTGF. First, CTGF is associated with fibrotic responses of many organs. It's elevated in human DMD and in animal models of the disease, and has been shown to induce a dystrophic phenotype in normal animals. In MDX mouse models that represent DMD well, Pamrevlumab treatment decreased tissue damage, fibrosis, and loss of muscle strength, and increased exercise stamina in MDX study. So there was also improved function. So our hypothesis is that inhibition of fibrosis in DMD with Pamrevlumab may increase the contractile capacity of dystrophic muscle, slow disease progression in DMD patients. So the goal of this trial, 079 trial, is to estimate Pamrevlumab efficacy and safety in non-ambulatory patients with DMD. So now, after giving this background information, I would like to present some highlights of the ongoing trial, 079 trial. So this is open label, single arm study of up to 22 non-ambulatory boys which are 12 years or older. This trial is currently enrolling. Each patient will receive Pamrevlumab by IV infusion every 2 weeks for up to 52 weeks, which is the initial phase. And the patients that achieve a less or equal 5% decline from baseline in FVC percent predicted by week 52, they then can go or qualify to move forward to the extended treatment phase of 26 weeks. The treatment duration, including extension treatment now, is 78 weeks. The primary objective of this trial is to estimate efficacy, which is preliminary efficacy and proof of concept, evaluate safety and tolerability, and assess PK and PD of Pamrevlumab in non-ambulatory boys with DMD aged 12 years and older. The efficacy endpoints are, number one, change in pulmonary function. We believe that by improving possibly the function of intercostal muscle and diaphragm muscle, we can improve FVC, maximum inspiratory flow, maximum expiratory pressure, peak expiratory flow, and peak cough flow. So this being measured periodically. We also study the change in upper muscle, body muscle function test, performance of upper limb, which is pull, grip strength, pinch strength, and Brooks score. Change in muscle fibrosis and fat by MRI imaging of biceps of the upper arm, and change in cardiac fibrosis and function by MRI imaging. So it's pretty extensive measurement, and we just want to detect some efficacy points. So the key inclusion criteria are at least 12 years of age, non-ambulatory, Brooks score for arms and shoulders equal or less to 5, diagnosis of DMD by medical history and also confirmed mutation by genetic testing. The patient must be able to perform spirometry. The patient must be able to undergo cardiac and extremity MRI. The percent predicted FVC must be between 40 and 90 inclusive. At least one historical FVC percent predicted value within 18 months of baseline. The left ventricle ejection fraction should be over 45% as determined by cardiac MRI at screening or within 3 months prior to day 0. Patients currently receiving heart failure cardiac medication must achieve a stable regimen for at least 3 months prior to screening. Must be on stable dose of corticosteroids for a minimum of 6 months with no big changes in the dosage for a minimum of 3 months. So now just the key exclusion criteria. The patient who requires more or equal 16 hours continuous ventilation will be excluded. The anticipated spine surgery for the duration of treatment within 78 weeks will be excluded. Severe uncontrolled heart disease, including any of the following: need for IV diuretics or inotropic support within 3 months prior to screening, and hospitalization for heart failure exacerbation or arrhythmia in the last 3 months, these patients will be excluded. Also, arrhythmia that requires antiarrhythmic therapy, hospitalization due to respiratory failure in the last 6 weeks, and poorly controlled asthma also will be excluded, and any underlying lung disease such as bronchopulmonary dysplasia, and this is because these diseases will affect the pulmonary test readout. Also, weight over 117 kilograms will be excluded, and exposure to another investigational drug or approved product for DMD within 28 days prior to start of study treatment, with the exception of the Deflazacort. These patients will be excluded. The Deflazacort is allowed. Now, this is a very busy table, but I would just like to present the schedule for screening and initial treatment phase for 52 weeks. So the dose is 35 milligram per kilogram, which was also established in previous indications, is given through the IV. It should not exceed 150 cc per hour and is given every 2 weeks. So this every 2 weeks schedule will be given to up to 52 weeks, and then there will be possible extension. The safety labs will be performed at screening, and then week 4, 8, 12, 24, 36, 48, 52, and 58, which is additional safety follow-up. The vital signs will be performed at screening and also every 2 weeks, which is before and after each infusion. Also week 54, which is end of treatment, and week 56, which is safety follow-up. The weight and height will be performed at screening and at weeks 12, 24, 36, 48, and end of treatment, week 54. The physical exam will be performed at screening, day 0, weeks 12, 24, 36, 48, 54, which is end of treatment, and 56, which is safety follow-up. The muscle function test will be performed at screening, which is day 0, and at weeks 12, 24, 36, and 54, end of treatment. So 1, 2, 3, 4, and 5 tests. The pulmonary function test will be at screening day 0, week 12, 24, 36, and 52. The cardiac and upper arm MRI will be performed at screening and end of treatment, which is week 54. The EKG at screening and week 52. Quality of life questionnaire day 0, weeks 26 and 52, and additional blood draws PK/PD for first 12 patients only on days 0, 2, 4, 7, 10, and weeks 2, 26, 52, and 56, which is safety follow-up. So the clinic visits will occur every 2 weeks for infusion. Each treatment period visit will typically take 2 to 3 hours. Some visits may last 4 to 6 hours when there is an infusion, but also specific tests scheduled. So this can be discussed with the doctor and also the case manager at the clinic. I wanted also to say which centers, we have 10 centers participate in 079 trial, and if we receive the phone call from a parent or a child or email wanted to participate in the trial, we will then direct the patient to the closest center or the center of preference, so to speak. So we have Cincinnati Children in Cincinnati, Ohio, Washington University in St. Louis, UCSF Children's Hospital in San Francisco, Children's Hospital in Colorado, University of Iowa Children's Hospital in Iowa City, Children's Hospital in Philadelphia, Boston's Children's Hospital in Boston, Shriners Hospital for Children in Portland, UCLA School of Medicine Children's Hospital in Los Angeles, and so this is UCLA School of Medicine Hospital, it's not a children's hospital, Children's Medical Center in Dallas, Texas. 10 centers. And before I finish this short presentation, I would like to extend our deep appreciation to patients, families, and DMD community which supports this trial. We would also like to thank PPMD for the opportunity to participate in this webinar, and most importantly, acknowledge the participation of patients and our investigators. Gustavo Lorente from FibroGen is a clinical program manager of this trial. He can be reached at glorente@fibrogen.com, and also phone number that's provided here, and you can read about this trial on clinicaltrials.gov. I just want to mention that Gustavo is extremely passionate about this trial. He's very proud of running this trial because he wants to show his own children that he's doing something meaningful, and he is very responsive to phone calls and inquiries, so please feel free to call him. I will also be available to answer any questions. And at this point, I think it will be a good time to answer some questions if any questions arise.
Thank you so much, Eva. We do have one question from the audience. We know that this trial is in an ambulatory or non-ambulatory population. Are there plans to extend researchers or clinical trials from a non-ambulatory population to an ambulatory population?
So certainly. We have selected non-ambulatory population mostly because we have been aware that there is a lack of clinical trials and options for these children. This was a proof of concept trial, and depending on the outcome or results of this trial, whether we see a signal with Pamrevlumab, we may consider at that point going to ambulatory trial. But at this point, the priority is to accrue these 22 patients where we can get a readout from MRIs, functional tests, etc., convinced ourselves that this drug works in DMD. Because if it does work in wheelchair-bound children, the chances are that it will help less advanced children, ambulatory children. So then we will consider this decision. But it will be premature for me to say at this point that we will be moving forward because it's conditional upon the readout of this trial.
Okay, so first we need to evaluate whether we can mitigate fibrosis in a non-ambulatory population, and then possibly discuss whether to further study this drug in the ambulatory population. Thank you. So the study is available to all mutations, is that correct?
The study is available to all mutations, correct.
Okay, and so for patients who may possibly be amenable to exon skipping and may be receiving exon skipping drugs, is that an issue for the study?
There will be an issue, Kathy, because as I said, we want to read out the efficacy. So if we would allow patients on eteplirsen on the study, we would really not know which drug contributes to improved efficacy if some occurs. So for the study's sake, we will not allow. There will have to be 28-day washout of the previous drug or 5 half-life, whatever is shorter. So that is exclusionary. These patients who are on other drugs other than the Plazacort will not be allowed at this point.
Okay, thank you. So if a child has been in any other clinical trial, they would need to wash out for 28 days or 5 half-lives prior to enrolling in this trial, correct?
That's correct.
Okay, thanks. Patients who might be on growth hormone, is that an issue for the study?
If the growth hormone is given as a standard of care by investigator, it will not be an issue. We'll allow it. If the growth hormone is given because there is scientific question asked and this patient is on clinical trial, then I would like to discuss this, but most probably we will not be able to allow it because we exclude other clinical trials. However, the standard of care growth hormone will be allowed.
Okay, thanks. So one of the questions is the difference between this anti-fibrotic drug and corticosteroids, which are an anti-inflammatory drug. But would you like to elaborate on the difference between these two compounds a little bit more, Eva?
So absolutely. When I was describing here today the pathophysiology of disease, we could see that the repeated damage to the muscle led to inflammation and then fibrosis. So from this diagram that I presented, this became very clear. Steroids are given because they can interfere or decrease inflammation. So the question is, and I will not have a clear answer, but the reason why I allow steroids and actually wanted steroids because there is a possibility of synergy between the two. And again, we don't have a clear indication, but they may synergize, they may support each other in this function by decreasing inflammation and then decreasing fibrosis at different points. So I don't have a clear scientific point, but from understanding the pathophysiology of the disease, I think there would be a benefit.
Okay, thanks. And steroids are required for this clinical trial, correct?
They are required because I understand some patients are off steroids, especially wheelchair-bound patients, and some patients are on steroids, and the doses vary. However, because our sample is 22 patients, we did not want to have too diverse of the population. That means patients off steroids and patients on steroids, because it would be hard for me then to interpret the efficacy signals or results between these groups, because the number is so small, I cannot do subgroup analysis really, and it's open label. So that's why we wanted to have this group a little bit more similar and allow steroids on these patients. I know that some patients do not have them, but from my interactions with the PI, I understand that most investigators provide steroids at different schedules and doses.
So it doesn't matter for this study which schedule or dose they're on, as long as they're on the same dose for 6 months prior to enrollment?
Correct, on stable dose, because these doses are adjusted according to patient's need. They are not necessarily titrated, but they are adjusted according to side effects, etc. So risk. So this is, I allow any dose of schedule that the physician may decide.
Okay, thank you. Well, there's a question about side effects. You mentioned mild to moderate side effect events. Could you elaborate on the potential side effects of this medication, or was there a fairly benign side effect profile?
It's very benign. Initially, you remember that the dose is calculated per kilogram, so if the patient is bigger, there was larger volume infused. So we have noticed that and adjusted to 150 cc per hour. And since then, we don't see problems. There are occasional, maybe headaches, they may occur, but they are transient. We don't need to give any pre-medications. There may be, any allergic reactions are very rare because this is human recombinant, so it's human antibody. We have looked through all the safety database and really on this 451 patients and did not detected any significant safety signals. It is very well tolerated.
Thank you. There was another question, Eva, about the difference in the results from the MDX mouse study. And the independent lab, the MDX mouse study was done in an independent lab, and the results weren't quite the same as your study. Could you elaborate on that just a bit?
No, absolutely, Kadi. So we had one with Dr. Morales on MDX. It's published. It can be reviewed. That show functional improvement that I have mentioned. And this was pretty encouraging. However, we do understand that the translation of research from mouse to human is not necessarily always there. So this is just an encouraging signal. We are looking for clinical signal mostly in this trial. There was another study done by different lab under different conditions, different housing conditions that also affect the phenotype of the DMD mouse that was negative comparing to the study that I have described. But that situation is frequently seen in the labs. So I don't draw any strong conclusions from this discrepancy at this point. My main focus is to see if there is a efficacy signal in patients.
Okay, thanks very much. One of the requirements is a BMI less than 88 pounds. And I'll admit I missed that you said that, but can you elaborate on that a bit and tell us why there's a weight requirement?
So there's a weight limit at screening, 117 kilograms, and BMI also, and that is because we are calculating the dose per kilogram, and the volume of the drug will be extremely large to infuse, so it will become very cumbersome for the patient and for physician. Infusion time will be long because I don't want to exceed 150 cc per hour. But the situation arose, and it can, with patients being on steroids, with this fluid retention, obesity sometimes, that the patient comes on trial with this weight and then increases weight, whether these patients will remain on the trial. And the patients will remain on the trial, but we will limit the amount of medication infused to 4.1 grams. So this limitation is for that reason and also only initially. However, later, when the weight increases, we'll allow this patient to stay on trial with the limit of the total dose to 4.1 grams.
Okay, thanks. And this infusion is every 2 weeks for a year. Is there the possibility that patients could have a port or a central line for these infusions should they so wish?
So indeed, Kathy, these conversations are coming up with our discussions with investigators, because some of these patients have good IV access and there is no problem, but many of these patients do not have good IV access because they are chronic steroids. Their blood vessels are frail, they may be obese. So in cases like this, the physician may decide and discuss with the family port placement. And when this discussion arises, we'll be very happy to participate and discuss if there could be any financial support that we can provide for this, depending on the institution, if it's needed.
Okay, thanks. So there aren't outcome measures that are drawn at every visit. Is that correct, or obtained at every visit? Every
correct.
2 weeks? Okay.
Yeah, that's correct.
Have you discussed the possibility of infusions being done at remote sites that are closer to patient homes, or is that not a possibility at that time, or at this time? And can you elaborate on that just a bit?
I will. We have discussed all kinds of options to try to make it easier for patients. And, for example, one of the options was home infusion, but logistically it became very clear, also with discussion with investigators, that because this is a new drug, tested first time in DMD, there could be a risk associated with this. It became logistically very difficult. However, the question remains, and the question, Kathy, you're asking is whether these patients could be actually infused in different centers. And I think this is something that could be done. For example, if the patient has a doctor in one center, but there's another center, and I have presented them, they are spread all around the country, that's closer. The two doctors could discuss and make arrangements or transfer, for example, responsibility for the trial to this another center. So we can be part of this and participate and facilitate these discussions. But my impression is that DMD community is very supportive of these children, and that doctors work together to make it easier for family and patients. So they easily relate or refer patients if needed.
Okay, so it sounds like if you are screened at one center and there's another clinical trial site of those 10 sites that's closer to your home, it's possible that you could go there for infusion. Is that correct?
So that will have to be discussed, because that will be an issue of the IRB agreement and PI agreement, because there is responsibility of the PI for the patients and for the conduct of the trial. So that is case-by-case basis. I cannot provide yes answer to this. I think the easiest situation would be to transfer patient to this other center that's closer to the home rather than carried. But I'm not saying that this is not possible, because it does depend how two institutions collaborate and whether such collaborations occurred in the past and whether this is feasible and whether IRB will agree or whether the hospital will agree.
Okay, but currently there's no plan to use sites for infusions outside of these 10 centers, correct?
Currently, there are no plans. These 10 centers are the only ones that are providing infusions, correct.
Okay. Because patients need to travel, are there travel funds available or reimbursement or any assistance available for patients?
Participants, Kathy, may be provided with a reimbursement for travel costs associated with clinical study visits, and this can be determined case-by-case basis. So please alert us early, and then we can initiate these discussions.
Okay, thanks. You also mentioned that if a patient is on cardiac meds, that they need to be on stable doses 3 months prior to screening. Are there allowances made for patients who may need to start additional cardiac meds or change doses during the study process?
This is allowed. So we do request on the screening that they had a stable cardiac medications at the screening, but we do understand that there is standard of care for cardiac conditions, that the condition may deteriorate. So these patients will not be excluded once they are started on the trial. This will be discussed with the physician, and the decision will be made so the patient remains safe. For example, cardiologists should be involved in those discussions because, and I do have those discussions myself when the situation arises, because we do infuse certain amount of volume, 150 cc per hour, for 2-3 hours. So if the cardiac condition significantly deteriorates and cardiologists may feel this is not safe for the patient, then of course patients will not be able to continue. But I have not seen case like this because so again, it's case-by-case basis, but these patients will not be included who need adjustments. Excluded.
Okay. All right. Thank you. The only other question that I can think of is vaccinations. Are there vaccination requirements to participate in the study?
Right. So pneumococcal vaccine is required, and also annual flu vaccine. And I do understand that some patients do have preference not to give these vaccines. However, we have discussed this with some of our advisors, and they feel very strong that patients should receive annual. That's basically standard of care for these patients because their respiratory status deteriorates, and when they have frequent infections like flu infections or flu infection in the winter season, this will affect their medical status, but also it will affect, this was not the primary reason, but it will affect the readout of the pulmonary function test. So I will require this on this trial for these reasons.
Okay, thanks. There are a number of outcome measures that you're collecting on a fairly regular basis, including pulmonary function tests, cardiac MRI, EKG, muscle function tests. Will the results of these tests be available for clinical management for these patients, or would those tests for any reason need to be repeated for clinical care?
This is a clinical trial, so I'm not readily, but this was open label trial, so we can communicate those, whether they would be used or not. I mean, because it's open label, physicians are aware of what this tests are showing. They are aware if, for example, upper arm tests are improving or not, the pulmonary effects are improving or not. Obviously, they will be aware, and obviously they will be able to, they can make decisions. They will have their own tests. I mean, they will make their own judgment, but this was open label. I can't, not disclose. They are aware of these trials.
Okay, so if a patient wants to have a cardiac MRI as a result of, say, on week 54, and they were in clinic, that the results of that cardiac MRI would be known to their cardiologist and could be used for clinical care.
The cardiologist will be aware. The cardiologist will be discussing this with the investigator. The investigator will be aware, and therefore the investigator, if he chooses, I believe, can make a decision based on this test. There is no need to repeat another MRI, which is very costly and also, difficult for the patients. I'm not saying that this trial is used to support the standard of care, because the standard of care should be performed as it is at the institution, but this is open label trial and they will be aware of this.
Okay, that's really helpful. I totally agree. Doing 2 cardiac MRIs would be kind of silly. Are there any other questions from the audience? I think we've answered everything. If there's nothing else, I think we've covered it all. I really appreciate FibroGen being on this call. Eva, thank you so much for giving your time, and the changes to this protocol, I think, will help enroll in this trial, and I think you're off to a good start. Is there anything else you'd like to add?
Just what you just say, Kathy, that we have analyzed, because in 1 year we have only 3 patients and there are no competitive trials in non-ambulatory children, or very few of them, so we were very taken aback and we analyzed screen failures. So we have released some of the inclusion criteria. For example, we only require 1 historical FVC in addition to baseline, not 2, in 18 months prior to screening. That should be really, according to standard of care, each patient should have that test. We also allow indefinite patients in wheelchair, not just 5 years or less. So that also should bring more patients. And I just hope that this change in inclusion criteria, which can be looked up on clinicaltrials.gov and is going to IRBs right now, will allow us to accrue more patients, because we truly hope to provide this drug to DMD patients if it works. And if we don't have patients, then we cannot guarantee that we can continue the trial or go to ambulatory population. So I would really like to encourage parents with children, especially in view of a good safety profile of this drug, children with DMD in wheelchair, and also investigators, to help us to accrue. With 10 sites, we just need 2 patients from each site to finish this trial. So we can really analyze, and you could see that we look at different measurements. So we should be able to read out from MRI, functional tests, pulmonary function tests, whether there is efficacy or impact on this advanced patient population. So we very much, Kathy, appreciate your help with allowing us to discuss this drug and this protocol and provide words of encouragement and hope that we can provide this as an option, because these patients do have few options.
Well, we very much appreciate your engagement with this community and with our patient population, Eva, and applaud FibroGen for participating in this trial. If anybody in the audience or anyone has questions or is confused about anything that was presented on the webinar today or about this clinical trial, please let us know or contact your local site via clinicaltrials.gov. Eva, thank you very much. We really appreciate your time.
Thank you, Kathy.
You're welcome. This webinar is concluded.